Xanthose has potential clinical impact, but way down the road, way down the road. It's important in showing the potential of anti-inflammatory therapy to reduce ischemic events, but how to do that and how to do it cost effectively remains totally uncertain. So interesting potential, but only potential at this point in time. Spiral, I think, is very questionable in terms of potential. At the moment, no. Whether it will resuscitate the whole concept of renal artery denervation for hypertension remains questionable. At the moment, I don't believe anybody will do anything differently in their hypertensive patients. Detox should have clinical implications, no question about it. The use of routine oxygen therapy in acute myocardial infarction has been questionable for years. Nevertheless, it's persisted. I think we have now clear data that routine oxygen therapy is not of value, and it can potentially increase afterload, potentially cause some problems. So I think from this point forward, based upon this, clinically we should not be using routine oxygen. EMANATE, I think, is going to have clinical implications. We often have patients admitted to the hospital with atrial fibrillation who require cardioversion. We've been using heparin to this point in time. There's data from this EMANATE trial that in conjunction with transesophageal echocardiography, you can potentially just give a single loading dose of apixaban and then go ahead and do cardioversion and promptly relieve the arrhythmia as well as make preparations for returning the patient home. So I think that that's going to have some clinical implications, and I think I may adopt that therapy in my own practice. COMPASS is one of those trials that I think may well have clinical application, but it still has to be sorted out. It's clear that there's a potential benefit of adding low-dose rivaroxaban to aspirin therapy in patients with stable coronary disease, and that has to be emphasized. The problem is you get a whole lot more bleeding. So I think that as time goes forward, that we may well give patients rivaroxaban in addition to aspirin if they're at very low bleeding risk and very high ischemic risk. On the other hand, if they have a significant bleeding risk, we're going to stay with aspirin. That would be my prediction. I personally don't think that the Precision ABPM study will have much clinical impact, and the reason for that is basically the data from that study has already been reported in the initial Precision manuscript in the New England Journal of Medicine. We know from that study and from this one that ibuprofen causes a little bit more hypertension, elevated blood pressure than the other NSAIDs, and particularly the COX-2 celecoxib. So that I'm going to use a little bit less ibuprofen, but Precision ABPM really didn't influence that. I don't believe that the PURE trial initially is going to have much clinical impact. I think the medical community is kind of bored with the concept of this diet is better than that diet. I think we're trying to focus on healthy foods rather than diets. I think generally most cardiologists know that you ought to limit saturated fats and you ought to limit carbohydrates, particularly refined carbohydrates, and that there are healthy fat foods and there are healthy carbohydrate foods. Now, whether or not showing that a study throughout the world has in fact demonstrated that very same thing, I don't think is going to change dietary recommendations at the current time. The thing the thing I took away from that I think is of greatest value is that in fact it's important not just to look at LDL, but to look at the whole lipid panel, risk panel across the board in terms of how diet influences it. So probably not a major clinical impact, but sure to cause a lot of conversation and a lot more argumentation.